Guys, so today we are going to discuss a very important topic, which is pneumothorax. What is pneumothorax? Pneumothorax is the presence of air within the pleural space, resulting in partial or complete collapse of lungs. Okay, normally what happens there is a pleural space contains a thin lubricating fluid layer, and this creates a intrapleural pressure, which is a negative intrapleural pressure. This negative intrapleural pressure is basically the cause of inward movement of the air into the lungs. When the air enters, this negative pressure is lost. There is a negative pressure in the lungs and the positive pressure in the environment. That is why the air moves from positive to negative pressure. That's why when we breathe and we inspire, the lung creates a negative intrathoracic pressure, and there is positive atmospheric or environmental pressure, and the air moves from the positive towards the negative. And then when air enters into the lungs, negative pressure is lost, lung recoil inward, and ventilation is impaired. Okay, and what is the normal pleural anatomy? So this is very important in knowing about the pathogenesis or the mechanism for the pneumothorax. So in the normal pleural anatomy, pleural layer, there are two pleural layers. One is the visceral layer, which covers the lung surface, and the other one is the parietal, which lines the chest wall. Okay, and in the pleural space, this is the, for example, this is the visceral layer, here is the lungs, okay, and this is the parietal space, pleura. Okay, and this is the pleural space, which is covered by which contains 10 to 20 ml of fluid, which is the pleural fluid. Okay, and this fluid maintains the negative pressure, and but the function is it facilitates lung expansion during inspiration. In the normal physiology, intrapleural pressure is during the end of expiration, it is -5, and in inspiration it is -8. And in importance is that in this negative pressure keeps lungs expanded and prevents their collapse, and the loss of this negative pressure results in pneumothorax. And if we talk about the epidemiology, the primary spontaneous pneumothorax is common in young males, thin, tall individuals, smokers, and its incidence is more in males. When we talk about the secondary, it is common in COPD, asthma, cystic fibrosis, TB, and interstitial lung disease. Now we talk about the classification of this, and we talk about the classification. These are classified into 4 types. Okay, one is the spontaneous, which has 2 types, primary and secondary. The other one is traumatic, and traumatic has blunt trauma and penetrating trauma. Then is the iatrogenic, which has central venous catheterization, thoracocentesis, mechanical ventilation, and lung biopsy. And the most important is tension pneumothorax, which is a medical emergency. Okay, we'll talk about these in detail. And this is a primary spontaneous pneumothorax, which occurs without underlying lung disease. And the pathogenesis, there is rupture of pleural, subpleural blebs, and apical bulla. If we talk about the risk factors, there are smoking, tall stature, male gender, and family history is important. Now we talk about the secondary spontaneous. So it occurs with pre-existing lung disease. Primary has no existing lung disease, and this has a lung disease. So common causes are COPD, TB, asthma, pneumocystitis pneumonia, cystic fibrosis, lung disease, lung cancer, and ILD. And patients usually have severe symptoms and greater hypoxia. In traumatic pneumothorax, the cause may be blunt trauma, penetrating trauma, or may be associated with hemothorax or pulmonary contusion. The iatrogenic pneumothorax occurs because of some procedures. The procedures causing pneumothorax include central venous catheter insertion, pleural aspiration, thoracocentesis, transthoracic biopsy, and positive pressure ventilation. These are the important causes of iatrogenic pneumothorax. And we talk about the pathophysiology. Air enters into the pleural cavity, negative pressure is lost, lung collapse, reduced ventilation perfusion mismatches, and hypoxia occurs. And severity depends on the size and underlying lung function. Okay, now we talk about the tension pneumothorax. So it is a one-way valve effect occurs. Air enters during inspiration and cannot escape during expiration. Okay, and results in rising intrathoracic pressure, mediastinal shift. This is important. You have to know in which pneumothorax mediastinal shift occur, and venous return decreases because of the pressure, and the cardiac output also decreases and can be fatal, and it is a medical emergency. What happens in the pathogenesis of this tension pneumothorax is that air enters into the pleural cavity, which results in progressive pressure rise, negative pressure is lost, positive pressure builds up, and lung collapses, and mediastinal shift occurs, and then compression of vena cava, which results in reduced preload and obstructive shock, and this obstructive shock results in death. The clinical features in the pneumothorax include sudden pleuritic chest pain, acute dyspnea, dry cough, and severity depends on size and presence of lung disease. So physical signs include tachypnea, reduced chest movements. On palpitation, you can have reduced tactile vocal fremitus, and percussion will have hyperresonance. On auscultation, decreased breath sounds and absent breath sounds can also be. So they're talking about the features of tension pneumothorax. The symptoms are severe dyspnea, anxiety, chest pain. Signs include hypotension, tachycardia, distended neck veins, this is important, and tracheal deviation away from affected side. These 2 points must be in your mind, and cyanosis, and it is a medical emergency. Now we're talking about the investigation. So initially, while we are managing a patient with a pneumothorax, the initial is ABCDE approach. Okay. Then we go for first line is chest X-ray, then ultrasound, CT, and ABGs. In the chest X-ray, there will be visible pleural lines, absence of lung markings beyond the line, and collapsed lung and hyperlucency. Look at here. Here you have lung markings. Here you have lung marking, but these are not here. Here there is no lung marking, and this is the lung. This is a pneumothorax. This is air in the pleural cavity, which is result in collapse of the lung. And in tension pneumothorax, there is also mediastinal shift, depressed diaphragm, and also here the esophagus will be shifted to the trachea will be shifted towards the normal side, away from the affected side. On ultrasound, point of care ultrasound, absent lung slidings, presence of lung point signs, and high sensitive in trauma settings, fast examination adjunct. Okay, in the city, you also see it is a gold standard imaging and useful for even for small pneumothoraces, bullard diseases, and underlying pathology. Look, this is the normal. Okay, and here you have, this is the lung and this is the air in the pleural cavity, which has resulted in the collapse of lung. If we talk about the ABGs, they may reveal hypoxia and respiratory alkalosis, and particularly important in secondary pneumothorax and COPD patients. Now we're talking about the differential diagnosis of a patient with the pleuritic chest pain and dyspnea. First one will be embolism, pulmonary embolism, then asthma, COPD exacerbation, pneumonia, MI, pleural effusion. Talking about the management, so the management depends on the type of pneumothorax, size of pneumothorax, symptoms, hemodynamic stability, and underlying lung disease. In emergency department, we first start with the, as we talked about this earlier, ABCDE approach: airway, breathing, circulation, disability, exposure, and then we administer high flow oxygen monitoring and IV access with the 2-bore IV cannula. In the management of the primary spontaneous pneumothorax, in which there was no any underlying pathology, underlying disease, in the small and asymptomatic, if it is a small asymptomatic patient is vitally stable, normal, then it's only observation and oxygen therapy. If it is large symptomatic patient is not vitally stable, then we go for needle aspiration or chest tube drainage. In the secondary spontaneous pneumothorax, there is an underlying pathology, and these are more aggressive management requires. Usually hospital admission, oxygen, chest drains, and high mortality. Needle aspiration. Needle aspiration procedure involves insert cannula in the second intercostal space, mid clavicular line, or fourth and fifth intercostal space, anterior axillary line, and air aspirated. Now this one is obsolete. In the recent guidelines, this insertion of cannula in the second intercostal space is obsolete. Now we go for this fourth or fifth intercostal space. This is a triangle of safety. Triangle of safety. Okay. In the chest tube also we place chest tube in the triangle of safety. Indications are large hemothorax, pneumothorax, failed aspiration, secondary pneumothorax, tension pneumothorax may also tube placement, fourth or fifth, and safe triangle may. Okay. So what is safe triangle? Safe triangle is the lateral border of pectoralis major. This here, change the color. So this is the lateral pectoralis major muscle, lateral border of pec major, anterior border of the muscle coming from the behind, latissimus dorsi, and the fourth or fifth intercostal space. Here is the fourth or fifth intercostal space, and base of axilla. Here is the base of axilla, and is preferred site for the chest drain. Okay, so this triangle of safety is very important for insertion. In the management of the tension pneumothorax, don't wait for X-rays. Immediate is the needle decompression, then followed by chest tube insertion and life-saving interventions. Now go back to the color. Okay, so needle decompression sites include is a current recommendation. It is preferred in the fourth and fifth intercostal space, as we talked about earlier. The second intercostal space is almost obsolete. And in the surgical managements include, there are some indications for surgical management like recurrent pneumothorax, persistent tail leak, bilateral pneumothorax, occupational risk, pilots and drivers, and video assisted thoracoscopic surgery is an option for this, and the procedure include bulectomy, pleurectomy, and pleural abrasions. And advantage is less painful, short hospital stay, and lower recurrence rate. Pleurodesis is an important step in the management, and its purpose is obliteration of pleural space. Methods include talc pleurodesis and chemical pleurodesis. And the indications are recurrent pneumothorax and poor surgical candidates. What happens in this is that this is a normal, this is lung, okay, this is a pleural visceral, and this is the parietal, and this is the pleural space. What happens in the pleural diastasis is we remove this space. These both lines are joined, and there is no pleural space left to create such hindrance. And then the complications include the respiratory failure, recurrence, persistent air leak, infections, re-expansion of pulmonary edema, or pneumothorax. And the recurrence factors, risk factors for recurrence include smoking, most important, then COPD and bullous disease. And recurrence rate is in primary is 20 to 50%, and smoking cessation has significantly reduced the recurrence rate. And the prevention include most important step for all the pulmonary diseases: smoking cessation, avoid scuba diving and air travel. And the prognosis in the primary has excellent prognosis. Secondary depend on the underlying disease and lung reserves. Thank you so much.